Thank you. Lesion sets, which type for which operation? I was given this paper by Professor Jill from St. Thomas's here next door. It's a paper by Mo going back to '64 actually, and quite surprising. He designed actually a computational model to predict atrial fibrillation, and already then he describes actually initiation of wavelet which propagates randomly across both atria. Surprisingly, all of what he said then comes true right now. Mark already discussed a bit about the electrophysiology. I'm going to highlight perhaps from a different angle. Up to now, there are three main theories. First of all, the multiple wavelet theory. Secondly, focal discharges at the base of anatomical structures like pulmonary veins, posterior wall, and the superior caval vein. And thirdly, localized re-entry with fibrillatory conduction. A second very important thing is the atrial remodeling. At a certain point, AFib becomes AFib because of the histological changes in the left atrium that occurs. And of course, there are also other mechanisms like genetics and like cardiovascular risk factors like hypertension, obesity, and so on. This is a very nice paper by Hezegier, came out last year, describing the relation between triggers, pulmonary vein triggers, automatic triggers, reentrant triggers, about modulators like atrial stretch, volume in the left atrium, and then the upcoming of substrate. And this describes actually how paroxysmal AFib can become persistent on the long run. All of these things results in a variety of patients with a variety of pathologies that need a variety of treatment possibilities. And this is reflected by a slide I already showed actually at the lunch symposium. Here you see actually results of a Belgian registry. In order to get reimbursement from the government for the material we used during the ablation, we had to perform a prospective registry. And you see the difference between paroxysmal and non-paroxysmal treatment patients, mitral, non-mitral, and different lesion sets. And the results vary enormously. This slide depicts on the left-hand side the triggers in pulmonary vein, in paroxysmal atrial fibrillation. And as Dr. Gilleneuve already alluded to in the paper from Hezegier in '99 in New England Journal, probably in paroxysmal standalone AFib, 90% of the triggers origin from the pulmonary veins. This is not so in our patient population. There, probably only 70% of the triggers origin from the pulmonary veins, but the left atrium also as a whole and the right atrium play an important role. This reflects in what we do. This slide is based upon the theory actually of Jim Cox, where the sustained drivers are described in the persistent patient, the non-paroxysmal patients. These drivers also sustain AFib around large anatomical structures like the pulmonary veins, like the body of the left atrium, like the body of the right atrium, and the thick lines describe sustained drivers that we know as atrial flutter lines around the coronary sinus, around the isthmus, and around the right atrium. What do we have to do then in concomitant paroxysmal patients? If we isolate only the pulmonary veins side by side, we will only achieve a success rate around 50%. If we then exclude, and I repeat, in paroxysmal patient, the left atrial appendage, we will increase that number by 10% and achieve a success rate around 60%. If we make a box lesion, we will increase the number up to with another 20%, up to 80%. If we create a full Cox-Maze-4, we achieve, as described by Jim Cox extensively, a result of sinus rhythm after our procedure around 90%. So what are our surgical options? We can either ignore and do nothing, but we won't achieve any good result with regard to AFib after our procedures. We can exclude the left atrial appendage and decrease our AFib ratio by 10%, but we will be also effective when it comes to stroke prevention. If we do a PV isolation plus a left atrial appendage occlusion, our success rate will be around 60%. If we do a full box lesion and an exclusion of the left atrial appendage, our success will be 80%, and the full Cox-Maze will result in a 90% success rate. Again, here we were talking about paroxysmal patients. What about concomitant, persistent cases? Probably there, the full Cox-Maze is the only good solution. We can either ignore it, our success will be 0 when it comes to AFib, no stroke prevention. The substrate in the left atrium here is less than when it comes to our paroxysmal patient, and we will only achieve a success of 5%, but our risk for stroke will disappear. If we do PV isolation plus left atrial appendage occlusion, also here our success will be low, only 5%, because these sustained drivers in persistent cases are much larger, and we do not exclude them by only isolating the pulmonary veins. We at least need to create a full box, and then we will achieve a success rate of around 40%. If we make a full so-called left atrial appendage, left atrium maze, our success will be around 70%, and the full Cox-Maze also here, as in the paroxysmal cases, will achieve a success rate around 90%. Dr. Giranov already alluded to biatrial left-sided lesions only, and I can only reflect what Richard Whitlock describes in his meta-analysis that came out in 2017 in Europace. There, the relative risk of a full biatrial approach was 2.8 versus 2 for only the left-sided full maze. And this difference was not statistically significant. The only thing was that also here, the pacemaker rate was slightly higher for the biatrial approach. And this all resulted in quite firm guidelines as reflected by this slide. And I think the STS are the most strict guidelines. They came out in January of 2017, giving a 1A recommendation for mitral valve surgery and a 1B recommendation for aortic valve and CABG surgery. So to come to a conclusion, I described you the relation between triggers and substrate, which is clearly different in paroxysmal and persistent cases, and balanced on the type of procedure and the type of patient you're going to treat, you need to define your strategy. And it's clear that a modified Cox-Maze-4 achieves at this point the best results. I also debated on the biatrial left-sided approach only, and finally, over the past years, the guidelines became quite firm with the STS guidelines recommending a 1A for our mitral valve cases. I would like to thank you for your attention.